Welcome to this live-streamed and recorded webinar hosted by Dearborn Academy and featuring speakers from the NE-PANS Pandas Association. My name is Rebecca Altpeter, and I am the head of school at Dearborn Academy. Dearborn Academy is a private, nonprofit, state-approved school in Newton, Massachusetts that serves students suffering from mental health and learning challenges. Our students have become risk avoidant, and many struggle from intense anxiety that make learning challenges like dyslexia even more challenging to overcome. We are incredibly lucky to have two of the panelists tonight, Dr. Melissa McCormick and Peggy Chapman, as consultants to our team at Dearborn, which includes our Dearborn clinicians and our full-time nurse practitioner, Allie Conies. We have seen too many children suffering for too long, and these experts are helping us to collaborate with families and their outside treatment teams to make sure that we are leaving no stone unturned in the effort to regain health. The COVID-19 pandemic that forced us to cancel this event that was scheduled for last March, ironically has brought a sense of vindication for families of children struggling with the kinds of physical and mental health challenges that result from the insidious syndromes that you will be learning more about this evening. Vindication that viruses can lead to neuropsychiatric symptoms. We now know that some people with COVID are experiencing both debilitating physical and mental health impacts from the virus. This spotlight is an opportunity to encourage more people to consider alternative explanations and treatments for students suffering from learning and emotional challenges. Now I have the honor of introducing the Principal and Clinical Director of Dearborn Academy, Sheila Gouch. Sheila is a licensed independent clinical social worker. She also holds a master's in educational organizational management and is licensed as a principal, special education administrator, and school adjustment counselor. Sheila has been working with children with significant mental health needs for over 20 years. She began her career working with children in an outpatient treatment setting, then moved to work as a clinician at a residential treatment program where she stayed for close to 10 years. From there, Sheila moved to join a public school setting as a social worker, where she supported students in substantially separate programming and went on to develop and oversee the district's offsite transitional program. Sheila serves as the chair of her local Special Education Advisory Council. She has two children of her own who've required special educational services. Both were ultimately diagnosed with PANDAS. Sheila is an active advocate for PANS Pandas awareness. She co-founded the Massachusetts Coalition for PANS Pandas legislation. This group led the grassroots advocacy effort in Massachusetts that supported the passage of a healthcare bill that included both the creation of a PANS Pandas advisory council and a mandate that insurance companies must provide coverage for the disease. Sheila is a fierce advocate for children and was just named by the Massachusetts Commission on the Status of Women as one of the Commonwealth's 2021 heroines for her work. I am so lucky and proud to have her as my teammate. Sheila?
Thank you so much. Okay. Sorry. Thank you so much, Rebecca. I'm so grateful for the work we're doing at Dearborn Academy and to have the opportunity to work with experts in the field to ensure that our students can find the right tools to build new skills, find new treatments, and access elite clinical and educational supports to become the students they dream to be. I'm also grateful for my supervisor, Rebecca, and our entire team at Dearborn, who are so open to doing the next right thing for children every single time. I've gone to Rebecca several times over the last 4 years to ask permission to engage in leadership opportunities outside of Dearborn. First it was, I'd like to be the chair of my Special Ed Parent Advisory Council. Are you okay with that? Her response, will it help kids? Then I came to her and said, I'd like to initiate a PANS Pandas bill at the State House. Are you okay with that? Her response was, will it help kids? Truthfully, I wasn't too sure of my answers at the time. But then in 2018, my dear friend Karen and I went to our state representatives and senators and asked an insurance mandate be brought forward for the illness that our children have suffered from for years, to require insurance companies to pay for critical advanced treatments for PANS Pandas. It seemed a daunting task at best. Little did we know the bill had been brought forward by other hero caregivers 2 times before, and little did we know the amazing strength, perseverance, and kindness we would find in other warrior caregivers in Massachusetts. Over the last 2.5 years, caregivers in Massachusetts, with the support of others throughout the nation, fought to get the insurance mandate for PANS Pandas in Massachusetts passed. And on January 1st, 2021, not only did Governor Baker sign this legislation into law, allowing the access for the sickest children with PANS Pandas to receive treatment, but the law he signed also established a PANS Pandas Advisory Council to look more closely into this illness and the devastating effects it has on children. With this council, we hope to create lasting change in how we treat and identify these illnesses. This was a huge win. It not only created, it was the only the second insurance mandate passed in 10 years in the state of Massachusetts. And the advocacy for it was done largely during a pandemic when no one was even allowed in the State House. I am so proud, humbled, and truthfully awestruck to be here today presenting these amazing women from New England PANS Pandas tonight. This group jumped right in, and together with the Mass Coalition for PANS Pandas legislation, we all linked arms, along with countless others statewide, to support this legislation being passed. And honestly, this whole presentation was supposed to be done a year ago as we were being shut down for the pandemic. And this was supposed to be like a huge celebration for this legislation. So we're so excited that we can bring them back here tonight and really celebrate all that we've done. Together, these groups, New England PANS Pandas, the Mass Coalition, all these amazing caregivers in Massachusetts, put together the first ever in-person PANS Pandas Awareness Day in 2019. We were told it was the largest gathering they'd ever had at the State House. Following that, we did a virtual event in 2020 together for Awareness Day, and that had over 10,000 views. These women are fierce advocates for children and their families suffering from this illness, and I'm so grateful to call them my friends and fellow advocates. And there are also so many here today watching who linked arms with us and got this bill passed. This was truly a grassroots effort. So many fierce advocates came together to make this happen. We're live streaming this event to Facebook as well, partly because we now have this amazing technology that we all learned to use since the pandemic hit, but mostly to ensure that this Any PANS Pandas presentation can be accessed by as many people as possible. We are so grateful to have them join us to share their knowledge and understanding of PANS Pandas with all of us. Please welcome New England PANS Pandas Association.
Welcome to this evening. I'm Peggy Chapman. I'm a clinical nurse specialist in psychiatry, which is kind of the equivalent of NPs in psychiatry. We're just an older named group. And I have been interested in PANS Pandas since Dr. Susan Sweeto published a paper in 1998. And I saw some kids at that time which fit the description and treated them. And then over the years, increasingly saw more kids. Somewhere around 2010, things seemed to get much more explosive in terms of how many kids were showing up at my door. I think part of it was somehow infection rates of illness were getting higher, and as well as identification was more. And joining with some people who you're meeting tonight, as well as some other people, particularly Lisa Grisolio and some other people, Jennifer Vitelli, who co-chaired with Sheila the Coalition for the legislation, really advocated, ran parent support groups, and started us off from very little to growing very big and wide in terms of our influence and our educational efforts. So I'm going to spend some time giving you the basics of PANS Pandas. It won't give you details per your child if you happen to have a child with this issue. And we can answer questions as best we can later in the panel discussion. So I'm going to start by sharing my screen. Let me get that up. So first of all, move me. PANS Pandas, this is our mission. New England PANS Pandas is to educate, bring awareness in the community, and that's why we're joining you tonight. The goals of the presentation: what is PANDAS, et cetera, the historic perspective, how it works, identifying treatments, educational supports, and accommodations in school, understanding impacts on families. What is PANS Pandas? So first of all, it's an acronym for, first of all, it started as PANDAS, Pediatric Autoimmune Neuropsychiatric Disorders Associated with Streptococcus. Dr. Sue Sweeto, who identified this, actually identified it with a parent brought her the second child that she had with OCD following a strep infection. It got attention. The mother was saying, this should be looked at. And Sister Sweeto said, I think it should be. And although there were other things she was aware of at the time, this was the predominant presenter, which was streptococcus, and then a neuropsychiatric response. In 2012, it was expanded to include PANS, pediatric acute onset, because it turns out that there was growing recognition that not just strep caused these issues. We have viruses, we have Lyme and tick-borne disorders. Sometimes it's herpes or vaccines, occasionally have flares, different things and different inflammations. Increasingly, we're seeing mold as an issue and looking at it. I was not even thinking about mold until probably 2 years ago. And PANS is a subset of children with an experience like encephalitis. So encephalitis is an inflammation of the brain. In severe forms, it causes seizures, it causes people to be in ICU, but this is not as severe as traditional encephalitis, but the same events are probably occurring in terms of the brain being inflamed with some event that causes symptoms to become neuropsychiatric. Now, neuropsychiatric is a word that combines neurology and psychiatry, because what it's suggesting is in psychiatry form, it's not just a psychiatric event. There's something neurologically going on that causes the disruption. And that cause is, in fact, some of these things listed below, which is strep, mycoplasma pneumonia, you know it as walking pneumonia, Lyme, viruses, mononucleosis, herpes, flu, etc. Now, the area we're going to talk about today is called the basal ganglia. It's this blue area here. It's actually made of a number of structures, which you'll see on a slide listed later. I'm not going to list them all. But very importantly, it's central to the brain. And in brain development, we start here, and brains developed over thousands of years. And the frontal cortex was the last area that got developed, which is your thinking, your reasoning, your wisdom part that differentiates us from lower mammals in the evolution. But I also will point out how this area, some chemical tracks called dopamine in particular, go right through this area and then go to all these other areas. So that impacts what you see as PANS pandas in the diagnosis. So what happens is you get infected and your body creates antibodies to fight these infections. And these antibodies become misdirected to the brain, especially that area, the blue gang right here. And strep in particular, the antibodies to strep see this area, and because the cell is very similar to strep in its what they call cell mimicry, it's mimicking strep, it thinks this is the strep and starts attacking this area and some of the surrounding tissues. The autoimmune results in neuropsychiatric symptoms as well as physical symptoms, but mostly they present as neuropsychiatric when we call it PANS pandas. Back to Rebecca's point originally, which is COVID is showing people that a virus is actually causing a lot of neuropsychiatric symptoms. And if you read the list of side effects from COVID, they mimic very closely what we see in PANS pandas. The average age of diagnosis is between 4 and 13. You can see the predominant is this area. This is also because this is when strep is very high in the population. It used to be PANDAS was diagnosed through age 12. They rejiggered it to about 21, but all of us are convinced from knowing and meeting people that people have had PANDAS in their adult world as well. And the initial triggers can vary, as I mentioned. The symptom mix, which is part of the problem of identifying, is very different from child to child, although there's some similar things that most share. And the symptom variety can be mild, it can be really extreme. In these families who have kids with PANS pandas, we find about 71% have some immune problems. What does that mean? If you have Hashimoto's thyroiditis, if you have, so your thyroid has an antibody that caused it to fail. If you have lupus or rheumatoid, ALS, MS, probably Alzheimer's. There's a lot of illnesses out there now, celiac, another one, diabetes type 1, that are immune. They also now are talking a lot about diabetes type 2 and weight as it's inflammatory. So there's a lot of conditions that are connected to mental health, including poor diet, weight, cardiac conditions also have neuropsychiatric problems accompanying them. One comment is, we know also that one of the older people who was 26 at the time did suicide with PANS, and PANS, as you'll see, can cause extreme rages and extreme intrusive thoughts about you shouldn't be living. and she suicided right after she got diagnosed before her treatment. And her brain was autopsied per request of the parents, and they did notice that the basal ganglia was damaged in that autopsy. And we hope over time, if unfortunate events occur, that we can continue that research. So PANS pandas is currently, and I say currently because you'll see what it used to be in a minute, diagnosed by either a sudden onset of OCD, obsessive compulsive disorder, rigid thoughts, rules, repetitive actions, and or a severely restricting food intake with frankly different kind. This is not a traditional anorexia. They have fear of choking, frank refusal to eat. They fear if they eat, something will happen, somebody will die. They sometimes won't even swallow spit. And then, so pick one of these and then accompanied by only 2 of the following severe symptoms. One of the common is sudden onset is not always accurate in terms of when you start to notice something's wrong with your child. Sometimes it's not an overnight, although sometimes parents can tell you it was May 30th at 8 o'clock when my child became somebody different. But often when we track back people who bring us their children and they're really struggling, they don't respond well to meds, they don't respond well to the therapies that everybody valiantly tries, we can go back and often mostly find a sudden onset of something. It didn't last, maybe it kind of went and came and went, of different behavior or an OCD episode that just kind of came and went. And then later on, it shows up as very problematic. So these are the other 2, to get 2 of these, and I'll go into those. So behavioral regression, let's see where that's here. So anxiety, depression, sensory, I can't wear this, I can't hear that, your chewing is too loud, the noise is too loud. I may be screaming, but you can't make too much noise. Touch and clothing, some kids can't wear clothes all of a sudden, they can't put shoes on, socks on, that they had no problem going off to tennis before then, now they can't put tennis shoes on. Motor abnormalities, I'll address in a minute with tics, behavioral regressions, deterioration in school, and somatic. In detail, behavioral regression are things like baby talk, thumb sucking. All of a sudden you think, this 12-year-old's acting more like 4 or 2 or 6. It's just, you know what they used to look like and now they're doing it again. Deterioration in school is pretty serious in terms of short-term memory, processing speed, executive function, in particular visual motor. So this is how the brain sees and connects to your hand and transmits what it wants to do. And because visual is very important, in particularly math and science, you often see the child all of a sudden not doing well in that, and they may have been a math champion and all of a sudden they can barely add. You also see them kind of try not to do it, avoid it, lie about it, and it's because they can't do it, but they don't recognize why they can't. Somatic signs include sleep disturbances, inability to sleep alone. They pound your door down, all of a sudden they're up and out of their bed all the time. They talk, they fall out of bed, they sleepwalk. What's happening is their REM sleep, which is the state of dream, your body is supposed to be paralyzed, and yet they're not fully paralyzed, so they can act out a lot of this stuff. Stomach aches are large. And for a subset of kids, very importantly for us to know, is all of a sudden fully potty trained, fully bowel trained. They have urinary urgencies, sometimes stooling episodes. They can't run fast enough to the bathroom. They get there, they try, they dribble out a little bit, and now they're back at the bathroom again. The teacher often thinks they're avoidant. The kids calling from the bathroom at home because they don't understand what's going on. Urinary tract infections are looked at and then are negative. And so I'm missing a slide here. Oh, here it is. I'm going back here now. No, it is to talk about these. I don't know what happened, but anxiety and depression. Anxiety is huge in these kids. They're frightened. They have what traditional psychiatry could term as separation anxiety. Separation anxiety is when you're fearful leaving a parent often, you don't want to go to school, but this is a different level. This is an intrusive idea in their head that if they leave you, they may not keep you alive. There's a dread of death, of horrid things happening. They cannot tolerate the idea that they would be separated from you. This is far more increased than my daughter when she had separation anxiety, for example, and she would like chase after me when I went to the grocery store. But she didn't, once she was put back in the house or once I dropped her off at school, she went on with her business. Once she got over that, these kids do not recover from just going to school sometimes. Their depression can be intense. They're sad, they're angry, irritable. Sometimes they get psychotic in terms of extreme psychiatric situations. They hear things, they see things. They might think someone's listening through the canisters and the lights. They don't only want to whisper because somebody might be listening. And these are all in children who never had these symptoms before, etc. They also have motor abnormalities called tics or other body movements, kind of abnormal movements. Sometimes it is, a tic is an action like a cough, a hum, an eye blank, a head roll, a body roll, a hand movement. But they can also include spinning and back flipping. And this has been replicated in mice when they inject them with strep. I'm afraid I'm missing some other things, but we'll probably hopefully catch up what I'm missing on the slide. Now I'm going to show you hopefully a very quick video of what this looks like in families. Now I want you to notice a couple things. The first person, should I get it to work right, is a child with an NG tube up her nose because she could not swallow. She could only spit. And so they ended up within a very short period of time, only several weeks, she would not eat. They put a tube in her to feed her. And you'll see her every so often. Also want you to notice the look in these faces. Here's one that's really good example. They have a very odd look. They kind of stare ahead. We call it the deer in the headlight look. So I'm going to try and get out of my screen and go back to share.
I think that we were in exactly the same position about a decade ago. Even 5 years ago, we repeated the experiments over and over again, demonstrating this connection between the strep and the OCD. Probably the most effective of those experiments was using antibiotics to keep the children from getting strep and showing that that kept them from getting their OCD and tics back. I suppose there are some people who think new ideas are ugly because they're threatening. I never wanted, nor could I have ever imagined that I would be at the center of a controversy because we just were doing our job.
It's like a seizure. It's like watching your child be attacked by a ghost.
This is not my daughter the way she was like a couple weeks ago.
He's gonna pick things up and he's gonna throw them. He's gonna, hit at people, he's gonna spit at people.
Kids are not supposed to be perfectly healthy one day and then completely tormented and very psychiatrically ill the next.
She recognized that you can have obsessive compulsive features that come on following an infection.
Doctors linked Maury's obsessive compulsive behavior to a common ailment in children, strep throat. The likely relationship has been coined pandas.
Anytime a new idea is propagated, there is an opposition to that idea because it takes people out of their comfort zone.
It is controversial. The concept got out of control. Every child who had no onset of tics was getting a course of antibiotics.
And I don't really believe that antibiotics help OCD.
Why is half of this medical community so against this research?
It's this great abyss between the medical system and the psychiatry system.
I see this inflammation. It doesn't tell me that this is psychiatric. It tells me this is an organic disturbance in the brain.
There's just no one in our town who knows about pandas, who's been willing to be open-minded to it being anything except psychiatric.
One of the things that really sucks, so sucks, because you're so tired every day to read papers and understand stuff and talk to doctors and say, listen, figure this out. I'm too tired to read this shit and explain it to you. Just do something for my kid. Do something.
Okay, Sheila, you can stop it. Okay. Okay, so that was some visuals of what it looks like. This is what it looks like and some paperwork. So this is, remember I mentioned the motor graphic part. This is before an onset, a very nice, neat drawing. And this is what they're trying to do when they're just trying to compose in school. This is another example of while they were sick, they cannot draw lines, they can't connect the dots really. And this is the same child after being treated. So you can see the child's abilities are quite good, but during the time they're ill, they can't connect this in their brain. Now I went back, these are the parts of the basal ganglia that I mentioned. They're mentioned in a slide later. Here they are. And behaviors in this area already are noted to be tics, Tourette's, OCD, and addictions are already part of this. This basal ganglia is known to impact this. And here's the lines of things that it can impact. So these tracks, dopamine tracks, go through the basal ganglia. They can affect emotions, thinking, cognitive function, motor control. This is where tics and movement comes in, motor learning. They also come back here. Sometimes there's visual. Right here is the temporal lobe for emotions, including psychotic. How it works is that we have different immune forms. IgE is like a traditional allergy. Many of us are suffering right now from seasonal allergies. But IgG is the antibody in the blood. And it goes kind of slowly to get to the war. So they get, the Navy gets on the boat and they have to sail to where the war is. So after the infection, it can happen very quickly, but often what's confusing is it happens 4 to 6 weeks after the infection. This is the same process going on with the group of COVID children who have multi-organ system problems, and that they're noting that the infections, maybe say May 1st, and the psychiatric of the physical inflammation where their body's starting to shut down happens 4 to 6 weeks later. In people who have long haul COVID, what they're noticing, many of them, is they get out of the hospital, they're feeling okay, but then they start to develop psychiatric symptoms again 4 to 6 weeks later. So I say the PANS has created cell mimicry, as I mentioned. And so what I tell the kids and the families, as you are, is that the Navy has the wrong intelligence and they're shelling your basal ganglia. And brain scans have showed basal ganglia enlargement in both PANS, OCD, and Tourette, as you saw in the film. I'm not going to go into this much, but in addition to the swelling and the dopamine, this is a cell 1 transmitting to cell 2 chemicals that you might have heard of, like serotonin and dopamine. And this gets bothered by the fact that dopamine is the key neurotransmitter. And we have found abnormal levels of antibodies, meaning anti means attacking. So in this space, your dopamine receptors are all of a sudden being attacked, which leads to different behaviors in psychiatry. Dopamine is a critical chemical in your brain. It's all these functions. And then we also have a very important neurotransmitter called norepinephrine, which is created from dopamine. So norepinephrine is focus and dopamine is alertness. When you give somebody Ritalin or Adderall, you are touching on both of these chemistries. And norepinephrine is one stop away chemically from epinephrine, which is adrenaline. So it is the flight-fight response. Thus, we see tremendous amounts of anxiety and fear, frozen or flying. We have kids who want to jump out of cars, and we have kids who can't come out from under the bottom of the table. Physical symptoms you will see: increased heart rate, blood pressure, losing your air, kids sick to their stomachs, shaking, deer in headlights I mentioned, pupil changes, they're often very dilated. And also attention, mood, concentration, executive function are all impacted by norepinephrine being out of commission. These children can be extremely ill. The tics, all right, so one of the slides that are missing is about tics. Tics, as I mentioned, are movements. The original Swedo, Dr. Swedo you saw in the film, diagnosis was either OCD or tics. But in 2012, there was a consensus meeting, which included several of the neurologists you saw in that film, who would not sign on to the idea that tics were created by an illness like an infection. So in order to get this moving and get this further along in research, they took out tics as the main calling card and put it into one of the possibilities of the list of options as one of the 2 symptoms you can have. So tics would be whooping, wringing hands, barking, licking, all sorts of movement and sound, much like in Tourette. So many of these kids have diagnosis of Tourette, but it probably did not start as a Tourette. It probably isn't Tourette, but it looks a lot like it because they have really bad tics, which are both vocal and motor. And so there's a symptom overlap, which is this slide's about. They also have hallucinations, which I mentioned, so they get diagnosed with schizophrenia, bipolar, lupus, cerebritis, which is inflammation in the brain relative to lupus, an autoimmune disorder. Medical treatments include throat swab to rule out strep, but throat swabs are often inaccurate, both because of the swab has to be very deep into your throat, which makes you want to throw up, and most kids don't do that really well. And also because only about 50% of throats will show strep. Sometimes the strep is not in the throat. It's, for example, in the perianal area, the anus area. Nasal swabs sometimes need to be done. The blood work, if you have had strep, would show that you have an elevation of these two antibodies, so we do look for it in the blood. We also do labs to look for all these others, and here's some of the labs that are done. And these are sometimes also for inflammation. These are inflammation markers. But I want to stress that lab is not a diagnosis. The diagnosis is done with clinical information and clinical review, very careful clinical review, and then the labs support whether, you know, what you're trying to find. The treatment is a three-pronged approach. I won't belabor this a lot, but basically you're treating the medication, psychoactive medications, you're using some psychiatric medications and some therapies. You're taking out the source of inflammation, that's taking out the Lyme spirochete, or treating infection, and then you're treating the immune response with immunologic treatments. So treating one is you might use psychiatric medications, but these often have been done much lower and much slower than the traditional psychiatric meds, which is why often things fail. People are eager to help the sick child and the suffering family and the child, but they do what I used to do, which is give them regular doses, and that often doesn't work. Therapies can be tried, such as cognitive behavior therapy, OCD therapy, but we have all learned that when a child is really in a bad state, which we call an inflamed state, their brain's on fire basically, they often cannot absorb anything. They barely remember what they're doing. They don't remember day to day, minute to minute what's going on, because their brain is haywire. It's really overloaded with the inflammation. And if you've ever been sick and tried to carry on a conversation, you know how hard that is. Hospitalizations do occur because they can get severe symptoms. If you don't eat, you need to be hospitalized. If you're psychotic and trying to endanger yourself or others, you might be hospitalized. If your tics are so severe you can't eat, you might be hospitalized. The problem is psychiatry is not developed to manage medical, and medical is not developed to manage psychiatry. Many of these children will end up on psychiatric units despite their severe separation anxiety, and then that compensates them further. Medical units allow parents to stay, but psychiatric units do not. So hospitalizations end up being necessary, but often very traumatizing. Antibiotics are used very much because antibiotics are both taking care of the infection and also they serve as anti-inflammatories. So often what's done is a 1-month trial to see if you have any response based on what we know from the lab work, which antibiotic might be the best choice. And we dose at the same rates of the infection. The other thing we do is NSAIDs, over-the-counter Advil or Aleve, to see if we can get the inflammation down. And often we start with that because it's a very fast response while the antibiotics are starting to work. Discontinuation we do over time when no symptoms and flares are occurring, and we try it out. Sometimes it's a summertime because there's less germs around in the summer. And also for kids who are really struggling, a short burst of something like prednisone is very helpful to see if that will bring down the inflammation. Antihistamines are sometimes used. Clonidine and guanfacine are blood pressure medications, which are used to lower the anxiety and the adrenaline. And benzodiazepine, which is, as you know, like lorazepam, Ativan, Klonopin, are used because of the high anxiety and aggression. Traditional antidepressants are used, antipsychotics. ADHD meds rarely help unless you've already got a diagnosis of ADHD. If you're moving around the dopamine, which is what ADHD meds traditionally do, and you're blocked from the absorption of that by the antibodies, it just makes you worse. And all of times in psychiatry, if you're working with someone, you want to go very low and very slow. One thing you've learned is a little bit of Zoloft as an antidepressant might give you some help to help your anxiety, but going up to traditional doses, often things start to backfire. Cognitive therapy I mentioned and OCD therapy are really important when you've got the child in a little more calm condition. They can learn a lot. The parents often develop and need a lot more support in the beginning, and that's what you might be actually using your therapy for. Supplements and a diet, I'm not going to have time to go into. In heavy-duty immunotherapy, you might get prolonged steroids, IV steroids, and what's called intravenous globulin, which is a blood product that's taken from human blood donations, and it's a very big dose of IVIG, which is immunoglobulin, which means it's part of the immune system. And when you hit the body with a very large dose of this, it tends to regulate and re-regulate what's not working well. Tonsillectomies are sometimes done because tonsils sometimes harbor a lot of the bacteria that we can't get to by just giving a regular oral antibiotic. In very extreme and life-threatening events, which there are children who are at that stage, especially if they're not eating or they're trying to hurt themselves, the minute you take a watch off of them, they're trying to hang themselves or hurt themselves. They do what's called PEX, which is plasmapheresis, and that is where you take the blood out, strip it from its antibodies that are bad for you, and put the blood back in. That requires a hospitalization and a highly compliant patient, which isn't always the case. And a newer drug that's used frequently in rheumatoid arthritis called rituximab, and some other drugs like this, which reset the immune cells and regulate the immune cells in a more different way than current other therapies. Children can relapse, we call these flares, and things can happen. Tooth can be taken out, vaccination, a mold exposure. I've had kids go to rental houses and all of a sudden they're acting up and there's mold in the house. The stage from Halloween until late April is worse because that's when strep's higher, that's when flu's higher, that's when you're inside and confined to germs. As you realize from COVID, that was when the time was that people were supposed to not be at school because of the risk for that to occur. And then tick illnesses also are very, very immune dysregulating. This is Lyme, Babesia, Bartonella, Ehrlichia, and Rocky Mountain spotted fever sometimes. And if you have that as an underlying infection, if your child had a tick bite, or even if they didn't, if they had swollen joints or they had suspected you might have a tick, but the blood work was negative, one goes back to revisit whether or not that is in fact hiding there, and it's very immune dysregulating. There's a long history, I won't go into all this, of infection causing psychiatric symptoms, particularly syphilis before penicillin was used. The Spanish flu, which is the kind of 100-year-old flu that we are talking about compared to COVID, you had all these events. Bartonella has caused us rage and psychiatry. This is a tick-borne. And viruses, including one that they've identified in brains of schizophrenia and bipolar, are being studied all the time. Also, before COVID, which is SARS-2, there was SARS-1. That was mostly in Asia, so you didn't hear much about it, but that caused a lot of psychiatric symptoms. A PET scan can sometimes show brain inflammation, but it's very hard to get. It's not easily acquired. Tonsils, these are some of the research. Tonsils have shown higher cytokines, which are inflammatory markers of the kids. Mice exposed to strep started having what we call leaky brain barrier, which explains why you can get these antibodies into your brain when normally it would be protected. And this is a kind of a synopsis of a lot of the research, and I'm not going to be able to review all that tonight, but a lot of the research that isn't on the screen has shown that using OC, like this one, using azithromycin, which is azithromycin or placebo, much better outcome with the azithromycin group to kids with PANS-PANDAS. Eating disorders are also shown to have a role in the basal ganglia. The frontal striatal is part of the basal ganglia. And in 5 years of studies from 2011 to 16, 49 studies suggested an alteration in this area connected to anorexia. Also, I want to note that after an infection, they've noted an increase in people having bulimia. Roadblocks, you saw some of them mentioned in the film. This is really hard to diagnose. A lot of people are still very unaware of it. You're just sent to the psychiatrist who they should be aware of it, and they're not. Medical testing is not done. We operate in medicine, as Sheila would say, in silos. So we have, if you have a foot problem, you go to the foot doctor. If you have a psych problem, you go to the psych doctor. Very few people put it together. And sometimes when you treat the infection, it goes away, but it's not so severe. It's later when things really blow up that people have more symptoms. And this is where the detective work comes in, the very careful clinical review of what's going on in your children's medical condition. Many doctors believe it doesn't exist, and I point to this as an article here. If you want to see the opposing argument, please read it. I can't say some of his points aren't wrong, but he's also not really brought up on, he's not bringing up the more recent research in the argument. closing thoughts is kids can get better. The earlier the diagnosis, the better. If we had all the pediatricians trained to see and spot these children who they know and they've known for many years, many of them remember 4 to 12, and they've known these children to be different than the ones that are in their office screaming, breaking things apart, totally petrified, having OCD, having tics out of control that they cannot stay on the table for exam. They know something's happening. They go, well, go see the neurologist, go see the psychiatrist. But if they could do a tick test, a strep test, sorry, at that point, checking the bottom, checking their throat, a course of antibiotics if they have any positives with a lab test or a swab, then we would not see as much PANS-PANDAS. If you treat it quickly, then you're training the brain not to react to all this antibody reactivity. Symptoms are relapsing, I mentioned, and it takes a whole team, which you're going to hear more about. One very important thing is not to blame the child for their illness. I get a lot of questions about, is this behavior willful? You know, they're just being so difficult. I had a parent call me today because the child's in some kind of a flare. I think it's allergies, because he's got really bad allergies, and he's being really difficult. He won't go to school. He won't get dressed. He won't eat right when he's supposed to. This is a child who was fully functioning, getting rave reviews 2 weeks ago from his teachers. And all of a sudden he's back to what I know to be a flare behavior. And I'm going to now turn over to Michelle.
I am Michelle. I am a parent of 2 PANDAS kids that I'm going to talk about a little bit and try and give some perspective. I'm also involved in the board of New England PANDAS and have been, I think, I was counting while I sat here, I think for 7 years, which just the way time passes, I can't believe it's been that long. And I've probably held almost every position on the board. So I just want to talk from a parent's perspective. I'll tell my story a little bit and just give some what I wish I had known, which I think is helpful. It would have been helpful to me to know these things. My daughter, Peggy, made reference to this, woke up a different child in 2013. We can tell you the date and the time. And she just was about 4.5 years old and woke up a completely different child with worries and concerns and things that she had just never, ever, ever exhibited. You know, and the hindsight is so excellent where Peggy said you become a detective. We did just that. And of course, years later, we realized, you know, she had a stomach ache that week and I had her at the pediatrician and they had checked her for strep and it was negative. At the time, we didn't put all these things together, and probably was just a perfect storm for us later on, figuring out that Lyme disease was probably involved as well as strep all at the same time. Just to fill in the what Peggy was referencing, as parents, you quickly become doctors, so to speak. And no, we don't have the medical degree, but I have read books and articles and white papers that are way above my pay grade, things that I never thought I would have to understand or need to understand. And as a parent, when you're going through this, you'll just do anything you can to try and learn and figure what you can out for your kids. For us, the first place to turn one night at maybe 2 in the morning after she had finally fallen asleep at 4 years old, was Google. And when you Googled, at the time, I Googled sudden OCD, and that's what popped up was PANDAS, even in 2013, which is great because I know I've talked to a couple other parents who did similar things in 2009 and did not come up with the same results. So all of the parents out there, whether it's New England PANDAS or just PANDAS Network, all of these parents have done a great job of getting awareness out there. And Dr. Google tells me PANDAS, and you click on the link and it just takes you to all of the symptoms. And for us, it was like, you know, the sudden onset, and her behavior was just so off, and frequent urination and all of these things. We just went down the list and you just look at each other and, you know, you have a moment where you think we figured this out. And then you just realize as you keep reading that there aren't as many answers as you'd like there to be at that moment. So I think we've come a long way. If someone Googles it now, I hope that there's more help and more answers. I also have learned, you know, a lot about OCD. I knew very little about it. It took me a long time to realize OCD isn't what people think it is traditionally per se. For my daughter, the obsessive thoughts that Peggy was talking about really become so intrusive that she can't function. And when you see that happen overnight, it's just hard to believe. For my daughter, we have the flares, as we call them, the waxing and wanings, where we have months or years where she's almost back to what we might call baseline. And then we have months where it's really bad. And as far as her journey, I think if you met her today, right now, today, you'd have no idea the struggles that she has. She pitched 7 innings in a softball game yesterday, letting up 1 run. She's dancing out on the mound. She's the cheerleader in the dugout, and nobody would ever look at her and know the struggles that she's had. I think it's important for parents to know that, you know, there is help. Like Peggy said, there is treatment, there is light at the end of the tunnel. And that as hard as it can be at times, there's definitely kids who are able to move on beyond what you think is going to be the darkest times. And we had that this fall. So my daughter had been fine, more or less, with some little ups and downs and speed bumps for about 5 years. She received IVIG in 2014. And for her, that was a game changer. And now we're back to 2020, pandemic, homeschooling, or remote schooling. And for her, I think the lack of social activity really contributed a lot, as well as something else, we don't know what, triggering the biggest flare that she's had since 2014, probably. And now 6 months later, we've made our way back, and it wasn't easy, but we learn every step of the way. I'm just gonna share my screen here. So I wanted to just share a few things as a parent that Peggy kind of touched upon, and I think Melissa's going to touch upon. I think it's helpful for administrators and teachers to know, but also parents. These are the things I would have loved to have known. Managing multiple symptoms at the same time, and not just multiple symptoms. For our daughter, that meant OCD on one day. Her obsessive thoughts might have been about one thing, and you're getting advice and trying to work through it. And 3 days later, it's not even that same symptom or that same thing. It's very fluid and changes very rapidly. And that makes an extra challenge for parents. Upsetting the family rules and upsetting all. This is very, very true when you have multiple children, whether they both have or multiple children that have PANDAS or not. You know, we're in negotiations in this stage when they're in a flare. We as parents are trying to get them to eat, trying to get them dressed. As Peggy said, there's sensory things that pop up, and that's very true among many of these kids. Maybe trying to get them to school with the separation anxiety. And as parents, you know, there's no book, we all know that already, but we're really negotiating. What are we going to allow and not allow? How, you know, what will be okay? Is it ice cream for dinner so that they eat that day? It might be, but if you have a 3-year-old, they're also going to want ice cream for dinner. So as a parent, those challenges come out of nowhere. You don't get warning. It makes it very, very difficult to try and keep the family rules, so to speak, consistent. Recommendations from doctors or other practitioners versus reality. And I'll talk more about that in a minute. But, you know, I do remember a visit and a phone call, I think it was, with a nutritionist in the midst of a difficult time my daughter was having. There's no doubt that nutrition can help with these children and with PANDAS. But again, the reality of having a child take 7 supplements morning, noon, and night, or whatever the suggestion might be, or potentially to go gluten-free, not that that might not help some children, it's very, very difficult to implement those things in real life, so to speak, with your family and the kids and multiple kids in the family while mom and dad work. It sometimes feels like when we were in the weeds, so to speak, if we were talking to a doctor or a therapist, and they would say, you know, because they kind of give you homework, or have you done this? Did you start this medication? Have you tried that we talked about last time? And it kind of sink your head and you say to you kind of say, well, we didn't quite get around to it. Like you feel like you're saying the dog ate your homework. But the reality is that just day-to-day life sometimes is very challenging. So just want to make notice of that. And my advice there for parents is to be forgiving to yourselves. Living with a panda child is more challenging than most realize. I guess that's probably an understatement. And you saw some of the more challenging cases in the video that Peggy showed from My Kid Is Not Crazy. And I think all of us have had those moments. It's very difficult. And who you decide to share that with in your life, in terms of your friends or family, who really understands, who doesn't understand, how much time do you have to try and help those in your life, whether it be a spouse or someone helping raise the children, really trying to explain to someone what PANDAS is and what your child's experiencing when you just don't have a lot left to give. Those are the big things that as parents you're living with on a regular basis. And I think that I don't have any great advice, but I have some. So I'm going to go to the next slide. What do parents really need? Support, not blame. Do not scare or shame us or our kids. I think Peggy also made reference to that. I think we've all heard some variation of they need discipline or structure or to toughen up, whatever it might be. It is not useful. It's not constructive. And it generally, it breaks your heart. You're trying your hardest and not always feeling like you're winning. The second thing is helping us know what the red flags are, our limits for safety, when to call for more help, and what to do when things go from bad to worse. I think there's probably many, many other parents that share that moment of you don't know what to do. Not just there isn't a book on this, you don't know what to do. I think that the next bullet point is really important. Put together your own treatment team tailored to your child's specific needs. I probably wish I had realized that was going to be needed sooner. I don't know. We don't have any data on these kinds of things, but we have definitely left a pediatrician's office specifically because they don't believe in PANDAS. And luckily, I realized that pretty early on. It is very difficult to try and seek out treatment for your child if there's a pediatrician not on board with the diagnosis to begin with. Seeking out a treatment team tailored to your child's needs. I guess what I mean by that for us at some point, our daughter has been in occupational therapy, I think when she was 8 or 9. She has certainly been in counseling. She has someone who prescribes medication. She has received IVIG. She has received IV steroids. You need to find the people that are going to, like Peggy said, there's not usually just one person that kind of does everything. And we have a lot of resources now available to PANDAS parents that can help you find the people that are out there to help. It's that sort of corny Mr. Rogers quote, find the helpers. I think that's very, very poignant. And when it comes to your PANDAS child and getting them help, it's find the helpers, find the people that understand, find the people that are going to be able to give you the assistance that your family needs. Going to support group meetings if there's one in your area. I kind of put that together with don't forget self-care. I think that making sure that you, the caretaker, are doing something for yourself. Might be walking the dog on a daily basis. It might be going to meet friends on the first Thursday of the month or going to yoga class, whatever it might be. You have to find that time to care for the caretaker so that you can dig deep and give your child what they need. And this piece of advice has come in handy. Someone told me, so I like to pass it on. Get a day planner to help track symptoms. It can be very useful. I find that you think you're going to remember this. You think you're going to remember the behavior or the example or whatever it may be, and we just don't. We're just, life moves on. We're busy. I love that I used to use an actual cheap day planner, and now I use my cell phone. I've seen people video things to send to doctors or show to doctors. I think that can be really helpful. But also just using the notes section or the calendar on your phone to note something. For us, it used to be, I might just note that there was a really bad weekend where our daughter struggled with multiple meltdowns, whatever it might be, had really, really intrusive thoughts. And I would start to note it down. And then oftentimes you start to see a pattern develop. And, you know, 5 days after the behavior, you hear from a friend whose house she was at that that friend had strep throat. And you look back in your calendar and you go, oh, you know, and you start to learn yourself what the pattern is or what the triggers might be. So I think that that can be really useful, also useful when you're talking to practitioners to remember those things. I thought, oops, that's Melissa. The last thing I want to add that helps, I think COVID has, if we can find silver linings in COVID about finding your team, is that finding your team just got easier because virtual appointments are so much more available now than they were 2 or 3 years ago. So now we don't have to worry as much of, can we get there? This is far away. How are we going to travel? Sometimes Candace's children don't easily travel. And, you know, in addition to COVID perhaps shining some light on post-infectious disease, it's also made more practitioners accessible to our kids. So my advice is to take advantage of that at this point in time. And I'm going to turn it over to Melissa.
Hey, my name is Melissa Glenn Hyman. I'm a clinical social worker. I've been practicing for over 20 years, and I pretty much switched my career trajectory about 6 years ago after my son was diagnosed with PANDAS 7 years ago. Luckily, I had specialized in cognitive behavioral therapy and anxiety-related disorders prior to my son's diagnosis. And I say luckily because in my new career, it's really helped me to be able to support the kids and families I work with. Though I have to say, cognitive behavioral therapy, though it's, you know, one of the mainstream treatments for PANS and PANDAS, is not the end all be all. And it's not going to be the quick fix that like some doctors will say it is. So, so that's just my caveat, that I do practice that type of treatment, but therapy with the kids and families I work with is so different than a manualized treatment. So anyway, so I came to this through my son. My oldest was diagnosed with PANS or PANDAS 7 years ago when he was 5. And again, like Michelle, it was that sudden onset. So a year prior, he had been sick and had some symptoms. And I had said to my child team that I worked with at the time, I was in outpatient mental health, I said, I think my son has PANDAS. And every one of them said, oh, no, that's so controversial. It's really rare. That's not what your son has. It's the trauma from being hospitalized, X, Y, and Z. There were so many different things that they said it could be, but certainly not PANDAS. Well, a year later, when he had literally all of the symptoms, I took him to the pediatrician and they ran a strep test and it came back positive, and I said, he has PANDAS, and the pediatrician agreed with me. And so I was lucky in that I actually knew what PANDAS was. So even, you know, the support of my colleagues wasn't, you know, optimal because they didn't really know much about it. And so I ended up just researching as much as I could to be able to really support my son. And through that, I ended up joining the PANS as a way to really try to help advocate for my son, my family. And then because of that, it literally changed my life. It changed what I wanted to do, who I wanted to be as a clinician. And now I've spent the last 6 years pretty much primarily treating kids with Lyme, PANS, PANDAS, chronic illness, autoimmune disease, things like that. I worked at the Lyme and PANS Treatment Center for almost 4 years and have been out in private practice for a year and a half. So that's just a little bit about me. Also, after my oldest was diagnosed, we ended up, my younger children had softer signs of PANS. And they ended up both testing positive for Lyme disease and co-infections. My oldest also has Lyme disease, co-infections, Epstein-Barr, West Nile, you know, you name it, mold. So he runs the gamut of challenging illnesses, I guess. But luckily right now, I won't go into the details, but we're in a pretty good spot. We have a really good treatment team. And, you know, we take from a lot of different places. I'm not just using Western meds. I'm using Eastern. We do a whole host of things that aren't, you know, traditional. We used antibiotics for a number of years, steroids, things like that. And we do supplements. We do a lot of diet things to help, like low inflammatory diets, things like that. And, you know, we basically, our whole family went gluten-free. We went dairy-free for a long time, low inflammatory. My kids were younger at the time. My other two were, you know, he's now 12 and they're 8 and 7. So we started this when they were probably 2 and 3. So it was a little easier to get everyone on board, though it's still a challenge at times. But anyway, so that's a little bit about me. And let me see. Hold on, I can't, for some reason, I can't move my slide. I'm not sure what's happening. Oh, here we go. All right, sorry about that. All right, so the impact of the on the family. Obviously, Michelle talked about that. And as, you know, as a parent, I 100% resonate and empathize with the families that I work with. And I think, you know, because of my experiences, I see, you know, I get what they're going through. Obviously, everyone's experience is a little different, but, you know, when they're talking about rage or OCD or, you know, all of the things that happen, you know, it just touches me to the core. And even seeing that video, every time I see the guy in the red sweater, that like makes me want to cry, even watching it when Peggy was showing it, because it's like, we all feel you. We all have the shared experience, even though it's, you know, some kids' symptoms are a little, you know, some are milder, a lot are extreme. You know, we all as parents just want to do the best we can for our children. And one of my biggest pet peeves is the controversy surrounding this diagnosis. Like, once you've woken to it, I don't know how you can't understand it. Like, prior to the, you know, knowing about it, I mean, I probably was naive, wasn't as educated in neuroinflammation, obviously. But now I'm like, why don't people get it? Like, it just doesn't make sense to me. And I won't go into, you know, I have a whole thing about the controversy, but both of them touched on it a little bit, so I won't. You know, there's so much stigma around mental illness anyway. And then for these kids, it's like, you know, oftentimes, I read it was like 33% of kids who are diagnosed with PANDAS have gone to like 5 or more doctors prior to their diagnosis. And oftentimes what I see as a therapist, kids coming in whose parents are like, yeah, they've been on 8 psych meds. We've been through, you know, 5 different therapists. And no one is telling us that, you know, until we figured out it was PANS on our own or PANDAS on our own, no one was telling them. And so these parents are just getting the runaround. And, you know, I feel like through NAPANS and different ways, we're trying to really educate families. But it's so hard. These parents are really struggling to figure out and navigate this world that is so unnatural to them. I mean, even for me as a therapist, I was like, what is going on for my son? And it was the most overwhelming, terrifying, heart-wrenching experience in my life. And, you know, there's obviously still PTSD, and every time there's regression or rage or a flare, it brings me back to a place that was really, really horrible. And so these families who are dealing with this are really struggling to, you know, to just get by every day. And you know, siblings are not to be taken lightly in this. They're often, you know, they see and hear everything, but are often, you know, the parents are trying to figure out how to best support these kids. when they have really no clue what's going on. And siblings can be the target of rage or an OCD ritual, and can really struggle with, it can be embarrassed because their sibling is doing these really weird things that they weren't doing a month ago. And like, how do you help explain that to a sibling? So it's really, really challenging for all the kids involved. And there can be a lot of marital discourse because of it. You know, I know when my husband and I first started going through this with our kids, we weren't completely on the same page. When, you know, we had started on the same page with knowing it was strep and all of that. And when I really wanted to go forward with more testing for Lyme disease and other things, it really, you know, it was challenging. And, you know, we're healthy, we're, you know, good communicators, but it can test the most, you know, loving, you know, connected couple. So it's really hard if you're already struggling, and then you have a kid who's acting out explosively, and you know, if one parent has to take time off of work. I mean, I remember I was in an outpatient mental health center working, and I would have to shift my clients around all the time, or be like, sorry, I can't come in again today, because I was the one that would have to take time off because you know, my husband made more money than me, and he carried our insurance, and I was only working part-time. So it was like the expectation that I was going to be taking time off. And I think that's often what happens, is that one parent carries the brunt of not the brunt, but the responsibility of really helping support and, you know, act as the case manager for the family. Like Michelle was saying, like having the daily planner and all that stuff, like someone has to be in charge, because we are in charge of our kids' medical stuff. Like no doctor is going to really take charge of it. And I learned that quickly myself, but also with the clients I work with, like we're all in the same position of like, we may go to 3 or 4 different doctors, but we're the ones that hold all of the information, and we're the ones trying to like figure out and research and really try to get our kids better. So it really can do a number on the family. And discipline, like Michelle was saying, can look very different, because the rules that you once had may not be the same. Like you cannot realistically, you know, scream and yell at a kid who's in a total state of hypervigilance. Like their autonomic nervous system is out of control, and yelling at them and just, you know, taking things away, things like that, are counterintuitive and counterproductive to helping a kid who is in a fight or flight response. So it's really about, for parents, learning how to manage the behaviors and becoming creative. And of course, you're going to lose your mind once in a while on your kid. That's, I mean, it happens. But it's about learning creative ways to manage when things are going on, because it's really, really hard. And diet lifestyle changes, obviously, you know, there's different schools of thought on doing that. Personally, I do believe that low inflammatory diets can be helpful, and I've seen it with my own kids, and I've seen it with many of the kids I've worked with. So, you know, you do have to pick and choose sometimes. I mean, these kids can be on like 10 to 20 different supplements, so it's really hard, and they already feel different. So when you go into a birthday party and having to bring the gluten-free cupcake, it kind of does make them stand out a little bit more. But you know, I often explain it to the kids I work with that, you know, this doesn't have to be a permanent thing. It's really to help in the short term, so that we're really trying to reduce inflammation. We're coming from different avenues. But if you need a gluten, you know, if you want to eat a cupcake at a birthday party, you know, if your doctor says it's okay, the one you're working with, then, you know, we don't have to do things 100% of the time, unless, you know, you have celiac or something like that. So anyway, let me see if I can move to the next one. Yeah, so families are, some kids are become dangerous and violent and make threats of killing themselves, and actually say, you know, really scary things. So parents are don't always know how to deal with it, and they are experiencing major PTSD. So it's really being aware of that as a practitioner, as you know, I know there are school people on here, so it's really knowing that parents are really struggling because kids are having a hard time, and it is not the fault of anyone except, you know, a bacterial or viral infection that's causing brain inflammation, leading to outward behaviors that can be scary. Kids are afraid. You know, all of the kids I work with are like, I just want to be normal again. I don't want to feel like this. I don't like the way my body feels. I don't like what my brain tells me. You know, some kids have lost friends because they've been out of school for a year or two because they have to be on homebound instruction. Some kids have really invasive medical interventions and it's really scary for them. All right, and I'm going to skip the frustrations because I already talked about that. Yeah, so families really often feel like they're not heard or understood by some people in the medical community at times. And so that can be really challenging. Parents have been accused of Munchausen that I've worked with. There's been, you know, I've had to work with families who, you know, the risk is real of DCF taking their children. And, you know, that's really awful and devastating for a parent who's just trying to do the best they can for their kid. And I had said earlier, like often kids coming in to see me have already been on like several meds. If kids go into a psych unit, their medication can be changed. They may be given a higher dose. And, you know, for some kids, it can be like a paradoxical effect. Having a psych med, it could actually exacerbate symptoms rather than improve them. So you really have to be careful with the medication you give and like see someone like Peggy who really understands the intricacies and the nuances of this condition in order to, you know, get on the best psych regime if that's what makes sense. So it's 7:46. And I have a whole part of my presentation to do, so I just don't think I should go into the school stuff because we don't have time. I'm happy to share all of my slides, and you know, and someone had posted in the chat about wanting resources, and we have a whole list of resources too in our presentation. So Sheila, would it make sense just to skip the school stuff and go right to the question and answer?
Well, so I think, how many slides do you have?
Oh God, I probably have like 10.
Okay.
So I can talk about the academic. Why don't I just talk about this, what it can look like?
Yeah, that'd be great.
Okay, and then I won't go into how schools can help, but okay, so basically, so oftentimes I'm asked to go help families navigate the school system. These kids will often need either a 504 plan, an IEP plan, and definitely an individual health plan. Though I also understand some parents are super weary about putting having the school know anything about their medical issues because they worry about how that's going to look or what will happen if they do, if the school knows or if the school can be in touch with the doctor, things like that. So I'm super sensitive to that, but I do try to help advocate for kids in school because they often do need additional supports and accommodations when they have a diagnosis. I mean, some kids do not because they're able to totally hold it together and their processing speed and working memory and all of that has not been affected. But for the majority of kids I see, they are impacted. So often what we see is a loss of math skills, decline in handwriting, with which Peggy showed that pretty profound drawing of the before and after. And I've seen that firsthand. I see kids who come in and their handwriting is horrible, and once they have treatment, they're great, or vice versa. Like I've worked with these kids who are amazing artists and then they develop hands or pandas and can no longer, draw a stick figure. So it's pretty profound. For younger kids, it's often hard to know because they're not good writers. They've never been able to write. So that's a challenge. But, kids who could color or copy, things like that, if there are changes in those, that's also indicative. kids will have a hard time making decisions, and that can be part of their OCD or just their executive functioning, things like that. We'll also see poor short-term memory and a slow processing speed, so also impacting math skills. So kids who were formerly, could do geometry or algebra are really struggling even to add 2 + 2. So, and often for that, I ask for assistive devices like calculators or other things to really help these kids just to kind of support them. They also may have a decline in their creative work. I have kids who, because they're tired, they have low energy, they just don't have the stamina to do the things they used to do. So, and that can really be impacted at school. Or, with writing, they can't write in the way they used to write. So it's really hard, especially seeing the older kids when that happens, because they know that things have changed. So I know they really struggle. There's also an avoidance of high sensory environment. So kids often, they just have so many sensory overloads, from clothes to light to sound, that, they really need safe, quiet spaces in order to re-regulate. And I often see kids who are school refusing or work refusing. So in school refusing, these kids are really sick. And so we cannot expect always for these kids to get into a school building when they're literally like falling apart inside and out. I mean, with physical complaints, stomach pains, headaches, joint pain, all sorts of things. It's really hard. I do, I encourage it as much as possible, but there are kids who it's not possible and they do need homebound instruction. So, and then work refusal, they're not really refusing to do work because they are, being obstinate. They're not doing the work because they can't do the work. That's often what I'm seeing. And then perfectionism. So then the opposite end of the spectrum are the kids who are super perfectionists, needing to get straight A's, overworking, perseverating, writing, rewriting, erasing, like nothing is ever good enough. So those are things that you may see when working with kids in school. Again, difficulty with working memory and holding on to information. You may see a kid who is really super disorganized, seems like they have ADHD, becomes really impulsive, can't sit still, may blurt things out in class. Kids who have really poor time management skills that once were fine with it may have hard time transitioning from class to class or subject to subject. And then again, the fight or freeze response, like that's a really big thing that happens for kids whose brains are inflamed, where, the parts of the brain that Peggy was talking about earlier. And so, so PANDAS in the classroom, you may see obsessive behaviors, reassurance seeking, especially from younger kids, getting stuck on tasks and just not being able to move on, may needing to go back over things over and over, regression in skills, but also regression in speech or, even fine motor skills, things like that. Acting out behavior. So these kids who are raging at home may rage at school or, not be able to contain themselves. And then, very distracted, avoidant, again, physical complaints and unable to complete their work. So, all right, so I will end with that. But again, you guys can have the people on the Zoom can have access to our presentation. So anyway, so I will now, I guess, turn it back over to Sheila so you can do what you need. Thank you.
Great. Thank you, Melissa.
I have to, sorry.
Yeah, there were a lot of questions about school-based pieces, so we can try to get to some of those. So I'm going to make all of us come on to the spotlight so we can do our panel discussion. And I'm going to add me too. Great. Hi, everyone. Yay, thank you all so much. That was so amazing. And I know we have lots of Q&A going on, and I know, thank you, Dr. McCormick. So this is the amazing Dr. Melissa McCormick, who is joining us for our panel discussion. You heard Rebecca speak a little bit about her before. She does a lot of work with our students here at Dearborn and also does a lot of work in her practice, Holistic Pediatrics. Welcome, Melissa. And so I'm going to go through some of the Q&A. I know, you know, there's some, you can see some of them in the chat. If people have questions or kind of specific questions, if you can write it down, that would be great. Lots of people asking if the slides will be available. They sure will be, it sounds like. And then we're going to try to go through some of the questions. And I know Dr. McCormick answered some of them as well. So let's see. So someone asked if there's always a sudden overnight onset or if there's a spectrum of severity. I don't know if Dr. McCormick, you or Peggy want to take that.
I can take that. Yeah, I think there's absolutely a spectrum of severity. And this is why so much PANS is missed, because everybody's looking for that acute onset. And the acute onset might have been in the toddler years when the temper tantrum or behavior is presumed normal, but it's really out of the normal range. Or it's just much more subtle. So, you know, they're definitely, if you're looking for only an acute onset of symptoms, you're going to miss cases.
Okay. There was another question asking if Kawasaki's disease could be a trigger for PANS. And that's a...
Well, Kawasaki's is probably just a similar mechanism. It mimics COVID, multi-system inflammatory syndrome in children's too. We've just never found a cause for Kawasaki's, and it's probably because there's been a lot of focus on what is a single cause, and Kawasaki's is probably multifactorial. There are multiple infections that have been linked to it, including strep. So, yeah, so whether they're someone who's had Kawasaki's in early childhood has a higher risk of PANS later, or it's a continuum, I'm not sure. I have a few patients in my practice that have a history of Kawasaki's in very early childhood, and then PANS later on.
Go ahead, Melissa.
Dr. McCormick, can I ask a question about that? So I've seen a couple of kids who then were diagnosed with Lyme disease. Do you see any correlation between Kawasaki and Lyme?
Well, again, it's, I mean, it's just a sign. Kawasaki's is immune dysregulation, causing an inflammatory response with end organs that are all very similar. There's, you know, the similar theme of what can be affected by autoimmune or immune dysregulatory processes. And that's the brain, it's the heart, it's the skin, it's the joint, it's the kidneys, you know, rheumatic fever. So I think the fact that someone has had Kawasaki's suggests they have that autoimmune genetic predisposition, and then another exposure is going to has a higher risk of causing the similar dysregulation.
Thanks.
I know that Michelle did answer Dr. Baumel's question, but I wanted to thank Dr. Baumel for being here. He is an amazing advocate for our children as well, a pediatrician in Framingham. So thank you, Dr. Baumel. He was asking if he's seen many PANS patients flaring during the pandemic due to loose teeth or wiggling teeth. So just to say that out loud, that's a great observation. Okay. Sorry, I'm going to go to the questions again. Sorry. My kids don't probably know I'm on a webinar. Okay. Melissa, maybe this is a good question for you. Have you noticed that mindfulness helps? And are there any mindfulness tools mindfulness techniques applied to this diagnosis, guided meditations.
Sure. Yeah, definitely. I mean, it is not, I think it's in conjunction with a lot of other things, but certainly kids or adults even who practice mindfulness. I often do a lot of progressive muscle relaxation, breathing techniques. I do it's called water breathing, where you're breathing in for like a count of 4 or 5, and then breathing out the anxiety, rage, stress, whatever it is, but saying like to yourself, I release stress or I release anxiety. Those things certainly help. And just to get kids more aware of what's happening in their bodies, because things are so, out of control for them. I start a lot of sessions with mindfulness practice. I use it quite regularly. So it certainly is a technique that I use to help support kids and adults who are experiencing PTSD. I work a lot with parents who I'm like, let's just, let's try to slow ourselves down. But it's not the only thing. So it is the start of CV, like cognitive behavioral therapy and different interventions, but it's definitely something that can be helpful.
Sheila, if I can add something, I would just say, tagging on what Melissa just said, it reminded me, you doing these things when the child is not in a flare is hugely helpful, because when they are in the flare, they might actually remember how to do them. It's sort of like, you've got to get it started. It helps so much, whether it's OT or PT or therapy or whatever it might be, when the child isn't struggling as much. It really makes it more effective for when they are. I've learned that the hard way.
That's really great, for sure. So I want to let everyone know we were supposed to wrap up at 8. We're going to stay on until 8:30, as long as our panelists can stay on, or at least for another 20 minutes and kind of get through some of these questions. Is that okay with everyone? Okay. So one of the questions was, has trauma earlier in life ever been associated with this? Is the village of the family looked at for possible clues on child's changed behavior? So Melissa, I don't know if you or Peggy want to take this. I'll answer a little bit too, if you guys start.
I think certainly trauma plays a role in this. And early when I was starting to do this work, so I don't remember the research or anything like that, but I do remember hearing of cases that there was no infectious trigger that was the start of it, but it was actually traumatic experiences that caused the symptoms to present themselves. So I think trauma exacerbates a lot of things. And, if your body is in a state of hypervigilance because of traumatic experiences, it all plays into inflammation. And if you can't calm your body down, if everything else is under control, that can still lead to stressors and ongoing symptoms, I think. Maybe, I don't know, Peggy, what do you think?
Well, Peggy and I actually were just having this conversation, I think last night, Peggy.
Okay.
So that there's actually, part of the ACEs study, the Adverse Childhood Experiences study out of California, actually, when they studied children with who are now adults with adverse childhood experiences, they found that they have a number of autoimmune illnesses. So it's kind of like chicken or the egg, right? Like the trauma and the cortisol and the adrenaline and everything that happens from that limbic system firing up actually then unhinges the autoimmune system. So it kind of becomes a chicken or the egg. Is that what we kind of talked about, Peggy? I get excited to talk about this stuff because at Dearborn, we talk a lot about the neuroscience, and it's just fascinating, right? It's all grounded in science, which is pretty amazing. Okay. Sorry, Peggy, I answered for you. I got too excited. Okay. What should be in place for the schools to have on record for like specific accommodations? Melissa, you touched a little bit on this, but what things do you feel like are helpful that you've seen with your clients?
Certainly having a 504 is helpful just so that there's record of a medical condition. I think any documentation you can have from your providers so that you don't have to fight the school as much, because until you have that documentation, the school doesn't care. Not maybe Dearborn's different. I think it's no offense, but a lot of the schools I work with really want the documentation before they'll implement changes. I also think, I mean, you can always, it's your right as a parent to request intervention. So you can request an evaluation and they legally have to do it. So you know, if your child is changing, you know, if things have changed and they are going to need accommodations, whether it's a late start time, an early dismissal, partial days, or, you know, excused absences, that's a huge thing because you don't want your kid to become truant. So, and I think it's like 14 absences and then truancy is called. So, having, you know, I know for my family, having excused absences was a huge thing, and all the kids I work with, having that implemented, then having extended time on tests, you know, reduced homework. I often advocate for, you know, understanding the subject matter, like less repetition. Like if they know like 5 out of the 10, like just give them, like they don't need to know all 10, like just give 5 questions. You don't need to do all 10. If it's really for repetition, don't do it. Just give them what they need to know. But really, you know, no homework and stress, like COVID's been great with having less homework for kids. So, I mean, I'm not, you know, that's a whole other issue I don't agree with. Homework's a whole other thing, but for these kids, they certainly don't need to be doing homework every night. Like they're coming home and literally probably falling apart for the most part. Like they've held it together all day at school. Like it's not possible for a 4th grader to sit and do a math packet for an hour when they literally have just held it together for the day. So that's a big thing. A huge thing, get an assistive technology eval. If your kid, if their handwriting has started to change or their motor skills are different, an assistive technology eval will give you access to different recording devices, laptops, things like that. I know that, you know, that we have more access now because of COVID, but when things go back to normal, really having access to assistive technology, you know, something that you can record classes or you can do voice to text. Even there's math programs in the assistive technology that schools are using now. So it's really a benefit. So those would be some things I would say.
At the end of the slide deck, there's a sample letter that NEPANS provides, and then also pandasnetwork.org has a number of samples to notify the school that your child's been diagnosed, and also to ask, particularly in the grade schools when they don't have but 1 or 2 teachers, maybe middle school, early years, to notify you if there's strep in the classroom in particular, or the nurse to be clued into the strep in the school. Nurses often, though, don't know that a child's been diagnosed because they go home, it's 4 or 5 o'clock, they go to the doctor, they get a strep diagnosis, they're put on antibiotic, they miss a day of school, they're back the second day, and they don't have to go to the nurse with a note if they're only out 1 day. So they'll go up to the teacher and say, Mrs. Jones, I was out because I had strep. So the teachers will often know and can notify you. The emphasis is you don't have to know who the child is, you need to know it's in the classroom, because as Michelle talked about, journaling, which we really encourage, will tell us what is possibly the infection that started off a flare. Parents sometimes call me coughing and sniffling, and I say, and they're upset because the child's regressed, and I say, what about your cough or cold? And they go, oh, it's just a little cold. And I go, not to your child's immune system is it little cold. It is an inflammatory stimulus to them.
Okay. So the next question I'll lob to Dr. McCormick. I've heard of of a variety of theories on what the mechanism is that causes symptoms in people with PANS pandas, antibodies versus interferons.
Interferon.
Yeah. Thank you. Permeating the blood-brain barrier. I would love to hear the latest.
A lot of mechanisms. If you look at the research coming out of COVID, it's just the catchphrase is immune dysregulation. Our immune system has many arms to it, antibodies being just one of them. And so when we're talking about autoimmunity and autoantibodies, that through molecular mimicry can cause inflammation in areas of the brain, that's just one element of the immune system. Then we have T cells that work through another mechanism. We have the cytokines, including, interferon, and a cytokine storm in an area of the brain or the body can cause just as many problems. There's the, what's called the innate immune system. So, and that's probably the biggest problem with why PANDAS is so still poorly understood, or why some kids do not respond well to IVIG or conventional, traditional PANDAS treatment. Is either the infection is incorrect or the immune response is different than what is being treated. IVIG is only going to help a certain population with a certain type of immune dysregulation. So there's no one mechanism that's current. It's just that there are many mechanisms, and that's what makes it so challenging.
Okay, thank you. So what percentage of children develop PANDAS or PANS after an infection? Are boys or girls more susceptible? Probably a Dr. McCormick question again.
Yeah, I don't know those numbers. I actually don't carry facts like that in my head. Just no room anymore. I don't know if boys are a little higher, or actually maybe is it boys are higher? Yeah, and the percentage we wouldn't know.
It's about a 4 to 5 to 1.
Yeah, but the percentage would be incorrect because PANDAS is undiagnosed, so we just really don't know. So.
Okay.
I also think boys get sent to psychiatrists for acting out faster than girls. Girls are sent to get anxiety treatment, and they're thought of as anxious and, oh, so sorry. And boys are, put them on meds and stop the aggression. So I think that just your sex, this is true with educational issues anyway, ADHD. If a girl has inattentive and she's quiet, nobody diagnoses her, but the boy will have, the boys have much higher rate in ADHD as well of ADHD, and they're going to get noticed more because they're hyper. But it doesn't mean that the girl sitting next to him isn't in the same problem boat.
Sorry, I was just looking at. My daughter has always suffered from anxiety and depression. However, in the past month, she developed pretty severe OCD symptoms seemingly out of the blue. She did have strep this summer. How can I tell if this is a continuation of the anxiety and depression at a new stage or PANS-PANDAS? What test should I do?
Well, what you have to try to do is figure out when the PANS-PANDAS started that caused the initial anxiety and depression, because that's probably what it actually has been all along. But just, a medical workup for acute psychiatric change, and that should include an infectious workup that looks for triggers of neuroinflammation.
And so the great part of that advisory council that we just, that this amazing group, along with others, helped get passed, is that we will hopefully be looking to kind of bridge out and kind of develop tools for pediatricians to kind of be able to do these screenings more readily. Actually, out at Stanford, they've already kind of done this. They've trained up all their pediatricians in the area, I think in Arizona as well, right, everyone? And we're just a little bit slower here in Boston, but we're going to get there. So it's a great advisory council that's going to hopefully help us out. Let's see. Should all family members get tested for strep if a child might be impacted?
Yes, it's important to get strep out of the household. Oftentimes there can be a carrier that can be the trigger. Sometimes the child with PANDAS is the carrier, but it is really important to test everybody and make sure no one's a carrier.
It's also very common in mycoplasma pneumonia that people have mycoplasma and walking pneumonia and pass it back and forth and around. So if you're dealing with mycoplasma that doesn't seem to respond, that's another area to check family members.
Any known connections between, I don't know, I'm not sure if I'm going to be able to say this right, Henoch, Schoenlein, Purpura, HSP. Did I say it right? No, I didn't. You're laughing at me. and PANS Pandas. Listen, I do my best. What can I say?
It's Henoch-Schönlein purpura, which, you know, that is an autoimmune vasculitis. So it sort of fits in, it's a rheumatologic disorder. And that's often that's triggered after infections. So it's in the same idea of the same process as PANS Pandas, which I believe is a rheumatologic disorder, just hasn't found its place yet. So yeah, there is some.
I've treated a child who got it in middle school, was a really high outstanding student, and then started to slowly fall apart. Very difficult to treat. And it turns out that she had a tick-borne illness. So that was probably underlying her final outcome of becoming PANS in my doorstep, was because she probably had that tick-borne illness, and then she got Henoch, and who knows if that's connected because it's autoimmune. And then she was falling apart, and she became school phobic, and she had every diagnosis. She looked bipolar one time, she looked anxious another time, she had OCD another time, she had intentiveness another time, she was paranoid another time. We went through a sequence of diagnoses which finally clued me to the fact, in addition to the fact I was looking, but I couldn't find the lab work initially to say that's what it was. I had suspicions, but she was a classic person who could have gone through all diagnoses if she was with a traditional psychiatric person. And what was really remarkable, not so remarkable when you think about it, is there was hardly a med that did a thing for her. High dose, low dose. She'd get a little bit and then she'd get a side effect, or it was just impossible to give it to her. And, you know, finally with herbals, actually, along with the original antibiotic treatment, because she couldn't tolerate the antibiotics either, she got much better.
So some folks are kind of asking about, I'm not going to go into all the specifics. I think what we can do afterwards is kind of send out some of those resources, but folks are asking like kind of what the course of treatment often is for a child with PANS Pandas, or kind of where you might start if you once diagnosed. Antibiotics, and then kind of what's the next step after antibiotics often.
Well, if you recall from Peggy's talk that the 3 arms of treatment are addressing the infection, addressing the inflammation, and then using psychotropic medications or addressing the neuropsychiatric symptoms while you're working on the underlying cause. So it really depends on the underlying infection, which hopefully you can identify. Sometimes you can't and may have to presume it's strep or something else determined by a clinical history. And then the first line of anti-inflammatory treatment is the use of non-steroidals like ibuprofen or Aleve. And that's one layer of just trying to knock down the inflammation that underlines this. And then depending on symptom and improvement with the first line of treatment, you might have to escalate either the immunomodulatory treatment to get a broader sort of broader control of the immune dysregulation. But to begin with, it's usually an antibiotic and anti-inflammatory, unless it was some other kind of like an exposure. If it's mold, then you're trying to eradicate mold, you know, other non-infectious exposure. And with the viral triggers, you don't have the option to treat those. They will run its course, so you support with anti-inflammatories or whatever mechanism you think is underlying the immune dysregulation, trying to help that, repair that.
Great. There were a couple of questions around autism spectrum disorder and kind of differentiating between the two. Peggy, I know you've done a lot of autism work. Do you want to take that?
They are two distinct, and they can happen in the same person. There is, you know, a large portion of kids with autism who have a regression. They call it regressive autism. And they are looking at a lot of biologic markers for those kids. There's a lot of work done on gut health, on inflammation, on exposure to viruses that they think may be triggering in those cases versus a child who's had autistic behavior since they were infant. And the majority of kids diagnosed with autism at this point, I still think is regressive. You know, they had a typical childhood progression most of the time until they're 18 to 24 months. But there's a subset of children with autism who definitely get PANS, PANDAS, and often it's a shift in symptoms. Sometimes it's, but some of the same treatments work. Diet has a lot to do in autism. Gluten-free, dairy-free, they really benefit from anti-inflammatory. They benefit from a lot of help with their gut, a lot of help with mitochondrial function, which is their energy sources, which I think also often go kaput in Lyme tick-borne disorders. You know, their mitochondria and their energy is so sapped. So it's not thought to be one and the same, but people who treat autism and PANDAS feel that they are often accompanying. You know, it's like a child who had a lot of stims, but then he started spinning and spitting in the air in a kind of a dance. And this was a sudden onset. So the mother asked us to look at that. And we found out they lived in a small town with a small church, and a lot of people in the church had strep, and they kept passing it back and forth. And so when he started acting up, the mother just asked questions, does anybody have strep right now? And the answer was always, yes, it's in church, the church membership. So you can, you know, you have a baseline of your child, no matter what they have, whether they're quote typical or atypical neurotypically. Treating psychiatrically, it's always a challenge with anybody who's got a neuroatypical feature, like autism or genetically driven things, is much more difficult and tricky to treat with psychotropic drugs. They are low and slow, but also they have many more side effects. And so just treating symptoms of, say, anxiety or depression in autism is tricky enough. Then you add in the layer of PANS, PANDAS, it becomes even more tricky. But definitely kids with PANS, PANDAS are not immune from getting PANS, PANDAS. They're not protected in any way. Just like for a long time, people thought erroneously that you could not have ADHD if you had autism. And that did not change until we went from what was called DSM-3 to DSM-4, actually, to DSM-5 in the last 2 years. But most of us recognize, of course, people had autism and ADHD, a subset. In fact, there's now considered to be a high cohort of ADHD in autism spectrum, along with anxiety disorders.
Okay, so I'm going to ask one last question. I do want to acknowledge that there have been a lot of great, really personal questions that have come in through the chat and through the question and answer. And I want to make sure that when we send out the resources, perhaps we can send out kind of, I know Dr. McCormick, you have kind of a initial workup list, so like maybe we can send kind of some possible blood work as well if people are interested in ruling it out, and really kind of talking to your pediatrician about kind of next steps. And then the amazing people at NEPANS PANDAS, Rebecca has pointed out that there's actually, if you go to their website, you're able to ask questions as well, and ask folks for, you know, to kind of give, I think, more directed
non-medical advice, but yes, advice
yeah,
about
non-medical advice, but perhaps places where people might be able to look for support.
Yeah. And we also have on our website, we have a whole list of recommended labs or like initial labs to be doing. So yeah.
There's also from the PANS Physician Network a document called Senior First Child with PANS, PANDAS, designed for a pediatrician. And I don't know, I think that may be posted on PANS Network, or maybe it's on NEPANS. I can't remember if it's there as well. But that would be a document to try and find. It's called Senior First Children with PANS.
I don't think we have that on ours.
I think it may be on pansnetwork.org.
Yeah, and it's just really important. I think you heard from Michelle and from Melissa, and I would say it as well as a parent. You really have to be a fierce advocate. You really have to be kind of in it, asking those questions and asking your pediatrician and all of the specialists to take another look. And if they're not willing to, then really asking, there's an amazing network of caregivers out there who are willing to, you know, pretty much, I think probably most of us on this call have picked up a phone and really helped. I know I'm so grateful to the people who picked up the phone for me to talk to me about my children. So, but the last question I'm going to ask is thoughts on vaccinating our PANS PANDAS kids. That's what we're going to leave it with. So, sorry, that's a big one. I know both my kids are vaccinated, so I'll say that. But Melissa or Peggy, you want to take it away?
Is that, you mean COVID vaccination?
Yeah, sorry, vaccinated. Yeah, COVID vaccination.
Okay. I think it depends on the state of the immune system. That's sort of how I'm approaching it, what the state of the child is. I think we know COVID can do some pretty tough things to kids who are at risk for immune dysregulation. So we want to prevent that. That said, but vaccines can induce the same kind of immune response. So if someone's not in a great place or in the midst of a flare or fragile or just coming off one, it may not be the time to vaccinate, but that's not hard and fast. That doesn't mean because the vaccine itself isn't safe, it's just it's not safe for them at that time. If they're in a good place and have been healthy, I think, you know, the benefits of the vaccine outweigh the risks, and preventing COVID is, you know, certainly worthwhile.
I want to add that, as Sue Sweeto would say, if you think getting the vaccine flare is bad, wait till your child gets the flu and see what happens to their immune system. And I want to say that I've treated a couple kids that I'm pretty sure had COVID because of one of them who was older described it to me to the T, but it was his sister who had a minor PANS episode 2 years before, very minor, just treated with Advil and everything went away. Massive psychosis all of a sudden, just really, really bad. And it went on for months trying to get her restabilized. And this was in isolation most of the time from COVID. So it wasn't like she was getting a lot exposed to a lot of their germs, but probably out of the 4 siblings, 3 had it in February before testing was available. You know, in those days, you just remind people, unless you had respiratory issues, you couldn't get a COVID test. But 2 families I know had children with undiagnosable pneumonias around February vacation, and they couldn't figure out what they were. They didn't, they didn't respond like normal. And it was the siblings who got really bad PANS side effects. So I'm asking, and I'm not always a great vaccine fan personally, but in this case, I really feel like we have to try and protect our children from really bad situations. And COVID, from what we know, is such an immune dysregulator that you can't count on your child not having that. So I agree with Melissa is that there's some timing issues, but I really do think people need to do that.
Thank you so much, all of our panelists and experts tonight, Melissa and Michelle, Peggy, Sheila, and Dr. McCormick. Thank you for joining us tonight. We had a lot of activity in the chat. A lot of folks want to learn more and feel like you gave them a lot of great information to take the next step with their child, or folks that they are serving in schools or in their practices, or at least start the conversation with their treatment team. So thank you so much for spending this time with us this evening. And I wish you all good health.
Thank you.
Thank you.